Good afternoon. I'm Aaron Gani, the founder of BehaVR. Our mission is to activate and sustain healthy behavior change using VR. So, chronic disease is almost the defining characteristic of our healthcare system in the U.S. These diseases are far too common. 7 of 10 of the top causes of death in the U.S. are based on chronic disease. They're extremely costly. We spend about $2.5 trillion a year in the U.S. managing chronic disease. And perhaps the worst part is they're largely preventable if we could just change our behavior, right? Exercise more, eat right, stop smoking, drink less. But that's easier said than done. That is a really tough problem. So what we're taking on is that last mile of behavior change. Most of us cannot make major changes in our health behavior on our own. There are not enough counselors and specialists in behavioral health to help us change. And with chronic disease in particular, comorbidities are the norm rather than the exception, which complicates things because then education and health literacy is even tougher. So what we're doing at BehaVR is taking prior proven protocols of clinical practice guidelines, cognitive behavioral therapy, underlying theories of behavior change, and mindfulness, and bringing them together in VR. Any VR company you should ask, but why VR? You can do it in VR, but why? We believe in VR, we can create complete focus, we can improve retention, and most importantly, we can elicit emotion. So we help people get in touch with what is their motivation for change. Why does this change matter to them? And why do they believe that they can make this change? And that's how we're going to activate and sustain healthy behavior change. We know these protocols work, but in an analog world, they're time-consuming and expensive, so we have limited access to care. If we digitize and scale this in VR, we can greatly improve access to care and reduce costs. So our platform is patent pending. We personalize and create dynamic experiences in a couple of ways. We ingest information from electronic health records. We capture information from participants during their VR experience, and we stream biometrics from them during their experience. We use all of that to personalize. Today we use rules. In the future, as we build our data set, we will use machine learning and reinforcement learning to optimize in real time. So everybody's experience is different. There are many use cases in behavior change. We started with smoking cessation. The World Health Organization says this is the #1 global social burden generated by humans. Number 2 is war, terrorism, and armed conflict. That's how bad smoking is, okay? Number 3 is obesity. We're partnering with Washington University in St. Louis, taking their decades of experience in weight management and obesity and bringing that corpus of knowledge to our behavior platform. And there are others lined up behind that. So we've got partners and potential programs in medication adherence, in perioperative programs, and the list kind of goes on and on. So a key thing for us really is focus. We have a number of target markets and prospects. The ultimate here is really general health. So think those entities at risk, at financial risk for the health of populations, employer groups and payers. The issue with these participants, you got to bring clinical data. So we're partnering with academic medical centers to prove that our protocol works. There are also narrower use cases in episodic health. So a couple of examples here are back pain recovery protocols, perioperative programs, where it's not a broad behavior change. You just need a patient to understand how they need to prepare, need to show up prepared, and they need to be compliant with post-surgical instruction, medication adherence, and the like. And that leads to the third major channel. We believe pharmaceuticals is a big area of opportunity here, both in terms of education for patients. This is your condition. This is why I've prescribed that medication. And then medication adherence, which is a tough problem with great alignment in the industry. We have a great founding team. I'm a 30-year veteran of all things technology, the last decade in managed care. Our chief medical officer is an orthopedic oncologist with a PhD in mind-body medicine. And he had a digital mindfulness business as well. And then our technical and creative team, they've got medical VR experience, computer game company experience, and a great team of advisors as well. So I started the company in April of 2016. Our smoking cessation product is in version 2 in the market. We're working on our first clinical study with the University of Louisville. And going forward, we're really focusing on figuring out the next best 1 or 2 use cases. We've just signed a deal with a chain of physical therapy clinics to do the back pain recovery protocol. This is, the total addressable market in this kind of a space is so big as to be sort of not useful. So we're really focusing on specific use cases and how we generate value and how we get to market. We know that this technology, we know the protocols under the technology work really well. The question is proving how we bring them to VR. So we're looking for a few key partners to help us do that. Thank you.
So do you plan on using this specifically in clinics? Or are you providing it to people at home for personal use? Because one of the biggest challenges, I think, is not everybody wants to put on a VR headset. And a lot of people that I've used VR on feel disoriented.
So a couple of things. We are deployed in clinics today. We started about 2 years ago, so we use PCs and Oculus Rift. Mobile really wasn't ready 2 years ago. We're about to port to mobile. We do think there are some use cases where we can envision, particularly with standalone headsets and the right use case, physician could say, look, I want you to take this home with you, think perioperative programs, that kind of thing. We've actually been really encouraged, though, with adoption or usability. In VR, you can make the whole user experience disappear. There's no buttons, no mice, no keyboards, no swiping. We keep it really simple. You look and you press a single button. We find everybody can use it. And our patients really, really enjoy it. We have a Net Promoter Score question we do in every session. And our Net Promoter Score is still 100%.
Aaron, you said you're in a clinical study with Louisville right now. My question is around what's your revenue model and who pays for this?
Yeah, that depends on the use case. So if I had it to do over again, smoking's a great problem. It's not an easy problem to monetize. So it's a shorter path to revenue in some of these episodic models. So the back pain recovery and the perioperative program are a lot easier because, frankly, you can drive physician efficiency right out of the gate. Even before you've proven that you can change behavior, you can save physicians time, which is a big deal. So the model is really a subscription model in clinics and provider organizations to start.
How do you scale up the content creation? Because this could go many different directions,
Yes.
and obviously, you'd like it to explode. So
Yeah.
how do you handle those costs? Seems like it's a big project to do that. Have you considered third parties doing it?
Yes. So I think the most important element of that is we are looking for clinical content partners first. So I mentioned Washington University. Dr. Denise Wilfley there has a team of folks that have spent 20 years working on weight management and obesity. We're looking to partner with Denise and her team, and we're in fairly advanced stages of doing that, to say we're not going to recreate all of their knowledge overnight. We're going to bring their content to our platform. And we have a similar approach going on in our perioperative program, and we think that's a model that can work by picking great partners out of the gate. Duke Medicine is another one in medication adherence that we're thinking about partnering with in that way.